Welcome to today's webinar, Pathways to Oncology as a Medical Student. I am Samer Al-Hadidi, and I will serve as a moderator and panelist for today's webinar. I am a third-year Hematology-Oncology Fellow at Baylor College of Medicine in Houston, Texas. I am interested in hematologic malignancies, especially plasma cell disorders, health disparities, clinical research, and medical education. I carry a master's degree in clinical research design and statistical analysis, and I'm currently on a T32 training grant. I conduct different research projects currently, and I am happy to be serving on the ASCO Training Council as a member for this year. Today, I am privileged to be joined by two stellar physicians and researchers. Dr. Shastri, she's a physician scientist and assistant professor at the Einstein Montefiore Cancer Center in the Bronx, New York. Clinically, she specializes in the care of patients with myeloid malignancies, such as acute myeloid leukemia, myelodysplastic syndromes, and bone marrow failures. Her lab is focused in therapeutic targeting of stem cell and MDS and AML, as well as large database analytics related to health equity in hematologic malignancies. She has been a mentor and educator for medical students, residents, fellows in the past 6 years. She enjoys mentoring as much as she enjoys research and patient care. And also, we have Dr. Warsame. She's a hematologist who specializes in the treatment of blood cancers, specifically multiple myeloma and amyloidosis, at the Mayo Clinic in Rochester, Minnesota. She's an assistant professor of medicine. Her research focuses on patient-reported outcomes, such as quality of life, how to ensure patients' voice is systematically included in their care, as well as financial toxicities in cancer care. She's also an associate program director in the internal medicine residency and diversity chair in the division of hematology. Good morning, Dr. Warsame and Dr. Shastri.
Good morning.
Yeah, hi, good morning, good afternoon, good evening, wherever you are in the world. And yeah, it's truly a pleasure to be here. Thank you.
Thank you. And I think as a beginning, I would like to hear both of you opinions on, what are the different types of oncology research that are available to medical students, and what did you think helped you the most throughout your career so far?
Yeah, Rahma, do you want to take that question?
Sure, I can. So there are so many types of research and paths to oncology. I think what I found most beneficial to me was first finding a mentor. I think that's significantly more critical than the actual research that you do, particularly early on. If you have experience and passion for the bench, finding someone who has the bandwidth and the ability to support you and knowing what you need. I was really green when I started. I didn't start really research until later on. Really my first year of residency is when I really started becoming engaged. Medical school, though, is a great opportunity now that I review applications to get started and find people. And there are summer opportunities where you can do a short course clinical research, even short course work at a bench, learning techniques. And it's more about understanding the processes as opposed to the product. I think manuscripts are very important, publications and presentations, but early on, it's more important to understand how a research question is asked and how that goes from a question to a study, and then the process to get to an answer accurately. And so I did clinical research at first, but then I shadowed in the lab when I came to residency. I tried a little bit of everything until I found the right match with a mentor and my personal interests.
Yeah, I mean, I guess I 100% agree with all the points that Dr. Warsame has made. I think finding a mentor is absolutely critical because at that stage, unless you're on a different track where you're doing an MD PhD program, having a good mentor is absolutely critical you're quite green, there's a lot of things for a medical student to learn, multiple different processes, experiments at the bench if you're interested in bench work, lots of things related to, just simple things like what is an IRB protocol? How do you write it? What elements go into these documents? What elements go into doing clinical research? What statistical tools do we use? So there's so much to learn. And I think just finding a mentor that inspires you, that you feel comfortable working with, I think is very, very important. And I highly encourage medical students to really seek out a few people and talk to them. Use the resources available to you through your medical school, whether it's like a director of research that helps medical students, or a specific office, or a mentoring program. Reach out to them and really try to talk to a few people where you are. And if you have interests that are beyond what's offered in your program, organizations like ASCO really give you wonderful mentoring opportunities at the annual meetings, or even online, to be able to connect with virtual mentors or mentors at other institutions that can help you.
Yeah, those are excellent points. Mentor for me serves as a buddy. You can reach out for when you have any questions. So, clinical research is not about just writing a manuscript and getting a publication. It's a learning process. And you will get all the help that you need when you find the appropriate mentor to guide you through that. So, can you share with us maybe some tips of how to find a good mentor? I know Dr. Shastri mentioned a little about ASCO virtual mentoring programs that are available and are excellent opportunities. But what other available mentoring you can advise the medical students to seek?
Yeah, so, I think that over the years, mentoring has changed significantly. I feel like when, just even a few years ago, the onus was really on the medical student or the resident to really go seek out who to work with. But I find that most residency programs and medical schools now have formal mentoring in place. You just need to be able to reach out to the person that can plug you in, actually, and have an opportunity to really meet with a few people in your field of interest. So as I mentioned, online, or just basically organizations like ASCO and AACR, these also do offer opportunities for finding mentors at outside, just outside institutions, things like serving on the ASH Training Council, merit awards. Conquer Cancer Foundation has a specific award which is directed towards minority recipients doing research. I feel like these are all great tools, to be able to really like grow in your career. Just a quick note about, just how to find, I think you kind of also brought up the point about how do you find a mentor. So I'm just going to reinforce on the point that I think it's really important to meet with a few people, whether that's virtually or in person, and try to get a sense of what kind of work they're doing, what their personality type is like. Are they approachable? I feel like these are all important things that it's good to get a feel for. And sometimes you may not know right at the beginning. It'll be more of a working relationship, but it's good to do, maybe even a couple of things if you're ambitious with two different people and see how things go.
I would agree. I think that, so I was really nervous. So that's one thing. So what I know now that I did not know then is that people really welcome the opportunity to support other people. But like Dr. Shastri was saying, I didn't know anything at the time. So like what's really key is also knowing yourself. Like what experience do you already have, and what do you need, and how do you learn? I really needed someone who was detail oriented and could show me stepwise processes. Other people, some of my current mentors, are very big picture. They've got great ideas, and then they leave, and then you come back with some sort of solid process, and then they like give you some more advice. I felt earlier on things I would do. I emailed program directors at my own institution, at other institutions, for advice. I also asked people just a little bit ahead of me, so like third years or fourth years in medical school, or first year interns. They just did this. They are working on it now. They can give you tips. I cold emailed, and it was well received. And now on social media, it's glorious. You can shamelessly address people who are extremely successful through a direct message, and it is really well received. People will give you advice and tell you they're not available, and then do something very small at first with someone, because if it doesn't work out, you really want to complete your project or have someone else complete your project, because a reputation is huge, and you don't want people to think that you commit to things, don't show up, ghost. That is just very poorly received. So start with something finite, unless you've got lots of experience, and then take on more.
Yeah, I agree. Both excellent points. Not always we could find the appropriate mentor from the first time. And I think it is okay to reach out for multiple people to see who will be the best fit. And before we get committed to a project where, there is a timeline, there is some dependency on you to do some part of the work, you make sure that the chemistry is okay. Everything is going to your needs. Because after all, the mentors and the availability of mentors, they are there to try to help you. And most of them take that as part of their job because of their interest. So they're interested to be mentors, and they will try to help. I think they need just to know what areas that you will need help with. Since we're going through the discussion, I would like to answer some of the questions that we get online. And we have a question from an international medical student, and she says that she's interested in getting a residency, possibly a fellowship in the US. And we want to hear, what do you think about research opportunities or mentoring opportunities as an international medical student outside of the US? So, Dr. Warsame, you can tell us what you think.
Sure. So there are a lot of different ways. It depends on where you are. If you're a fourth year medical student, I think if you're hoping to transition to the United States from internationally, if pre-COVID, if you could do an elective physically there, is a huge opportunity. And then often you can write up a case report with somebody, or just get to meet people, and then that relationship will extend even after you leave. You could do work with them. If you're already if you're earlier on, you could reach out. There are research, if you have time. Some people do a full year of research in the middle, and will do what is considered like a research fellowship in the middle of their medical school, and then they'll develop relationships. Often it's a very productive time to learn research techniques and processes, and publish and present. If you have a full year, that would be expected, that you would be productive, and that will be very strong for future residency applications. And then once you want a heme-onc fellowship, what you want to see is consistent growth, that people continue to do work, and that it wasn't early on and then stopped, that there's a continued interest and passion for research, I would say.
Yeah. I completely agree with what Dr. Warsame said. I'm just going to add a little bit to this. So, similar to you, I was also an international grad. So I'm a foreign medical grad. I did my medical school training in India. And a couple of tips that I can give you, so if you have certain visa restrictions or COVID restrictions during this time, like we mentioned, do reach out to people on social media and other places, email them and ask them if you can help them with some ongoing research, or if you could write a review article with them, share your experiences and your CV. I'm like we said, people are really open to collaboration and helping people out. So this is something that is worthwhile to do. Taking time off from in that transition between medical school to residency is also actually very helpful. It's a period of great productivity, and I think this is really a huge leverage for you in terms of fellowships. So since we're talking about becoming an oncologist, this could very well be your most productive time in terms of doing research and publications, because once you're in residency, your schedule is like chock full. You don't really have that much time to devote to research 100%. So maybe taking even 2 years off, is not a bad idea.
Yeah, I totally agree. I am also personally an international medical graduate from Jordan, and I think there is also a possible local opportunities that you may look at. And even if those opportunities or projects are not probably your ideal ones or the best out of the best, they will give an idea that you have the interest and you tried. And I think those are good things to start. And there is also some efforts from ASCO, for example, to do some virtual mentoring programs specifically for students, and some virtual learning elective, if you would call, for students, and that is ongoing and being developed. So that's another opportunity, specifically now with COVID and all the restrictions of traveling, that could be an option for international medical graduates. So let me switch gears and go to another question. Not I think that this question is interesting in a way that in medical school you may not know exactly what you will end up doing, and probably all of us thought about other specialties before ending up doing medicine, for example, or hem onc. So what can you share with us maybe what are the steps that made you choose hem onc, and then or like go through hem onc, and even if you decided about something else before you change your mind? I think this is a practical question for students. So Dr. Shastri, what do you think?
Yeah, this is actually a great question, and you're absolutely right. There are very few of us that are super focused and know exactly what we want to do from the get-go. Most of us will experiment, dabble in a few things until we finally decide what we like to do. So, I think definitely I've done all of that. I've sort of dabbled in a few things, but I think what really brought me ultimately to hem onc was a strong interest in cancer. So I'll tell you how. So I basically all throughout my high school and early medical school days, I worked on the side with tobacco control with a nonprofit organization. And I was very interested in this topic more from a policy and advocacy standpoint. And I spent like a few years definitely working on this. I learned a lot about just the various forms of tobacco, and how the legal loopholes are found with the tobacco companies worldwide to sell their products. And eventually it led me to understand how many different cancers are really caused by tobacco, and it was just very shocking for me. So that just made me explore this topic even more. And when I was in medical school, I actually was very interested in surgical oncology, and I did more surgical rotations than medical rotations. And eventually decided not to go into it because, there were restrictions being a foreign medical grad. And also the fact that, the lifestyle for me was not very attractive. Yeah, I really did not fancy being in the hospital at 4 a.m. in the morning. So there were two major factors for me, which turned me off from going down this path. But I actually found internal medicine at that point very attractive as a pathway to becoming a med medical oncologist. So I think it's nice to imbibe all the experiences you have, so keep your mind open to, all the experiences coming your way, and definitely, do a few things before you decide on what you want to do for the rest of your life, like live happily ever after with this particular field. And the other thing I would say is, we are living in an ever-changing world, and it's important to be flexible. Please, you should definitely have things you like, but it can't just be this one thing. You have to have a few options you would be okay to go with, is what I feel.
Excellent point.
Absolutely.
I totally agree. Dr. Warsame, you want to add something?
So I feel like I was really very naive when I started medical school. I thought that I would be the doctor and a sheriff of a small town and just like be able to do everything. But it wasn't until I started to experience rotations in medical school, and I found it really helpful to know what I didn't like. And I did not like the OR. So that was an easy, there goes OBGYN, there goes surgery. And I was like, well, that's good. And then I found the thing that I really enjoyed. It was like a culture. I found my people. I like chronic diseases. I like long-term relationships. I like really deep, gratifying discussions. I like incorporating myself into the family of my patients. And it just seemed like cancer was the place where I got all of that. I actually really also loved primary care. And I felt like I was really torn. And so I just did a couple extra rotations. And by the time I was in residency, I got to experience a lot of primary care. And I realized I missed those really long, deep, challenging discussions. And I found that really rewarding. And that's how I decided to do hem-onc. And I loved all different types of cancers. I became a hematologist really because I loved my mentor and I wanted to be her. And then I just started doing research in that area and really enjoyed it.
Excellent points. And I think this also reinforced the idea that it is okay to like more than one thing initially, and then see where you see yourself with time. Because we know we all went to medicine because we like medicine as a whole, and then we find ourselves probably in one spot there, or where we will be doing better and we will enjoy what we will be doing. So I would stay with you, Dr. Warsame, and ask you a question about people who are interested in getting into internal medicine residency, and then after that getting into hem-onc. How important is the research that they do before residency from your end, if you review somebody, for example, application?
That's a really good question. I think in medical school, the expectation um, really varies. I think if you have lots of, if you are at a major academic center with so many opportunities to do research, it's quite striking to see nothing, to not see a poster or a case report or some relationship. If you are at a school that has less opportunity, I think people appreciate grit and people who create relationships. And even if, and I think writing up even just a case report just says a lot, or working and doing work there, even if a manuscript never comes of it, doing some work with somebody really does show importance. I think that just is helpful for getting into a really great residency. The more research you have, it can help more, but I don't think it's that big a driver. In residency, though, to apply for fellowship, there is a significant expectation in hem-onc fellowships that you show academic prowess, because that is such a large part of the specialty, the dynamic research. It changes so fast and it shows like a real dedication. And so I think even more so in residency, showing continued growth and completing projects to manuscripts, going to presentations is more important than in medical school. But in medical school, it just sets you up for certain residencies.
Yeah, No, I completely agree. And just to add on a little bit to that, I just want to say that when you say research, I feel like a lot of people are fixated that it has to be a specific type of research. But, you have so much open to you. And, if you truly want to experiment with bench research, I would say go for it. Like Dr. Warsame said, you don't need to have a publication. The first project I did, actually, I presented it at a large meeting, but I never got a paper out of it. It was bench work, but it really fostered a love of the lab for me, which is very important for what I do now, since I do have my own lab. And the other thing is, so there's bench work, there's clinical research work, where you could work with, patient data sets. There's also quality there's QI projects, so quality improvement projects, which are also considered to be very useful. So there's definitely a few different categories that you could choose from, and you could always do something very meaningful. And even if it didn't result in a publication, you should not be discouraged.
Oh, no. Medical education is another aspect, curriculum development, just showing like you have an interest and ability to complete work in any capacity is really well received in medical school.
Yeah, I think those are important points because some of the medical students may think that research is the lab, and it's not all about the lab. It's one branch that you may like or you may not like. And I think clinical research have tons of opportunities for different things that you can do. And from patient care to clinical trials to health equity to data sets. You may need to look at what availabilities are around you, because as a medical student, you may not have the choice to choose a specific topic that you really want to do. But maybe if you're nearby an excellent surgical oncologist who is doing lots of research on a specific cancer, you can partner with this surgical oncologist, work with him or her, and get something out of it. So I think this is another important thing, is what opportunities are around you and how can you kind of figure out those opportunities. For the presentations in general, I think most of the venues allow medical students to have a separate kind of competition throughout their, case reports, abstracts, because we know that, big major meetings could be competitive to get an abstract there. But you have a priority as a medical student to get some of your work out if you apply for those specific medical students meetings, like the American College of Physicians, ASCO, ASH, and other meetings. So that also brings us to actually another question that was asked before this meeting is, what is the difference between a radiation oncologist and a regular radiologist or an interventional radiologist? And Dr. Warsame, you want to answer that?
Sure. Radiation oncology is a branch of oncology in which they use physics significantly. They also use imaging in order to determine how to apply radiation to specific parts of the body and for the whole body. And they address multiple different types of malignancies. And that's a radiation oncologist. A radiologist reads imaging of varying types, whether this is CTs, X-rays, PET scans, MRIs. And then an interventional radiologist does procedures using imaging to guide the procedure. I think that's all of them.
That's an excellent summary.
Yeah.
So,
those could be definitions. It's pretty good.
Yeah. So I think I will ask you, Dr. Shastri, what do you think about one of the questions we got? There is multiple ways into getting into hem-onc. A student maybe after medical school will spend a year or two doing some research, then going to a residency, then going to a hem-onc fellowship, or may go directly to a medicine or even medicine pediatrics residency and then a fellowship in hem-onc. What do you think about those two tracks? What do you think is better, or what are your thoughts about it?
Yeah, that's a great question. I think it really depends on a host of factors. So I don't think there is necessarily a better way to do it. I really think it depends on the individual preferences. So is a person okay with a more relaxed timeline, but you want to be able to get into, say, a hem-onc fellowship that is more academically rigorous. So if you want to get into a large academic center, uh, and you didn't have a chance to do like an MD PhD program as a medical student or something, I think it would definitely be worthwhile to spend a few years, devoted to research, or perhaps look at residency programs that do have a research track, that could offer you the opportunity to match to, a more academic fellowships. So I think that this is something to start thinking about, versus, there might be other people who feel like, I would rather just be done with my training, and then towards the end of my training period, kind of decide what I want to do, and I think that's an absolutely fine approach too. There might be reasons tied to it, like family or finances, or just the fact that you have training fatigue. You don't want to be in training for so long. You want to be done with it. I think it's okay as long as you have reasonable expectations in terms of, like your residency and fellowship matches. So I don't think there's a one approach fits all. I think it's important to consider your own circumstances, what you're capable of, and what you want to achieve eventually. So it's interesting. I know I don't really quote Harry Potter usually, but there's the principal Albus Dumbledore. I love this thing. He always says that it's not really it's not your really talent, but it's really what you want to do, that decides what you end up becoming eventually. So you don't have to think that what you have at the get-go is what's going to decide where you get to. You're going to develop abilities along the line, and you always have a chance to diverge if you don't like what you're doing at that point.
Those are great points. Another questions we got here is about patient populations that we all work with. And I think, this is very variable according to the subspecialty that the people work on. For example, Dr. Chastri do most myeloid malignancies, so specific kind of cancers. But in fellowship, you will go and do different kind of cancers, and most of the fellowships you will do also hematological diseases like sickle cell disease and so on and so forth. So for training, I would say you would learn it all. And then after that, you will come into the next step in your life where you probably either do part of it or some of it, but not the whole thing in most of the cases. What do you think, Dr. Warsame, about that, specifically your patient population that you treat?
I think it's just important to know what type of oncologist, hematologist you want to be. So if you want to be in practice, many of my good friends from fellowship went to practice, and they see a variety of things, and but they usually have something. Nowadays, it's so big and diverse that you'll be like 50% breast and then 50% anything else, and then some. That's what practice is even turning into, because it's so hard to keep up. I think in academics, you decide about whether you want a heavy research, do you want heavy clinical or bench? And then what is the disease specialty? You really want the disease you treat to be the disease you research generally. Although you can have treatments that are research that is disease agnostic. Like I do work in equity and financial toxicities. That applies to everybody. And I started in plasma cell disorders, and I usually expand it out because that's what I treat. But and then you want to know what type of relationships do you want. Some diseases are curable. Curable cancers are high risk, high reward. Like Dr. Shastri does leukemias. Or do you want chronic malignancies like my own, who are indefinite therapies? Sometimes they can live with it for a decade or more, but it doesn't go away. So it just depends on that. And then there are different patient populations even within that too that you can address, but I think I might get too granular.
Yeah. Yeah, just to quickly add to that, I think that's absolutely true. Depending on the type of cancer, you will see different patient populations. Depending on where you end up practicing, whether you're academic or in community practice, you'll see different patients too. So where I work in the Bronx is very different from where Dr. Warsame works in Rochester, Minnesota. So we have very different populations. About 80% of the patients I see are underserved, primarily Hispanic or African American, Afro Caribbean. And to be honest, I really do enjoy working with patients from more an urban underserved cohort. I've been doing this for years. And I really, and through my medical school and residency experiences too, I have realized I do enjoy working with underserved patient populations. So again, it's good to kind of get a feel for what things you like to do along the way.
Great points. And since we are on a similar trajectory, what do you think is better to choose from if you have the ability to choose? Is to go to an academic internal medicine residency followed up by a hem-onc fellowship, or a community internal medicine residency? What are the pros and cons about with those?
I would say that, again, I don't think there is a particular preference. I would say that if you are a person who has a lot of interest in doing bench work, or a specific, or research that is kind of really very involved, you would be better served in an academic program, because you will not have opportunities to do this in a community focused hem-onc fellowship. Whereas if your focus is more on patient care related research or outcomes research, I think you would do just fine at either places. If you are in a community oncology program for residency, I think it would be good for you to really make that extra effort to reach out, to find research mentors or things to embellish your CV, because this will make a difference when you match for fellowship. And I saw somebody on the chat had asked, how many papers do you need? It's not the number of papers which defines it, but more sort of the fact that you made an effort to do it. And if I see somebody from a community program had a presentation, say at an ASCO meeting, and it looks like they put in a significant amount of work, they're a first or a second author on that, that would definitely be very meaningful.
Yeah, I totally agree with that. And it depends on the opportunities that you may end up having. Academic internal medicine programs may be more competitive than community, and it's about what you will get. And I think once you get one of those, you can work to improve your research and work with what you have, because everywhere you can find something to work on. So that's an excellent point. We got a question specifically for Dr. Warsame. Can you speak more on the long-term patient discussions that you have with families? The question is for you. So tell us, what do you think about that?
This is one of my favorite topics. This is what I love to do. I feel like challenging discussions takes a certain nuance and time and kindness. In my mind, I think the foundation of all medicine is kindness. I think knowledge can be acquired, techniques can be taught, but I think kindness is super important. And having discussions with family members, because it really is a village. It's not just the patient. They'll have their spouse or children or parent. And when you really invest in answering and gratifying these people and understanding their goals and their quality, you can make very different decisions. So I called a patient's wife yesterday who passed away on Thanksgiving. And we've known each other for 4.5 years. AL amyloidosis, which if you don't know what that is, it's an exquisitely rare disorder that is very difficult to treat and manage, high symptom burden. And she sent me a thank you card, like her husband had died. And it's because of the time and investment to really get to know someone and make sure you meet and serve their needs, because the same cancer will have different goals for different people. And those conversations feel like I have had a rewarding impact directly on somebody. And so regardless of how many times my paper gets rejected or what grant may not get funded, it always is like the foundation and bedrock of my joy. And that's why I really love what I do.
That that's great, and that speaks for us where we go to this oncology fellowship, looking to be good at that and be good with patients, because long-term patient relationships, taking care of patients at the moment they really need you the most, even if you cannot prolong their life, it just make them feel better, make them feel that you care. I think this is all reasons for many of us to go into oncology and continue to like this specialty. Um, so for the time, I would try to go over a few questions left quickly. What do you think, Dr. Chastri, about non-PubMed indexed journal or publications? Are those good? What's your take on it?
Yeah, this is an interesting question. And, I feel like this has evolved a lot during COVID times. We see that a lot of papers, which could potentially end up in peer reviewed journals eventually on bioarchives. We see that there is a wealth of information that people have wanted to publish, but because of the stringent timelines with the peer reviewed indexed PubMed journals, people are trying to get them published wherever it can happen quickly. Of course, having a journal, with all this being said, I think if you can get your research into a peer reviewed PubMed indexed journal, it is always preferable, even with the extra time that it takes, because it indicates a certain amount of rigor that has gone into evaluating your research by independent reviewers. So I think it's always preferred. And, I think if you have the ability to do that, then, for sure you should go for it. But for some reason, if you're not able to get the topic, if it's judged not sufficient to have high enough priority for those journals, I would just aim to just get it published, or at least have it on the bioarchive until you can build up on this topic more to get it published into a peer-reviewed indexed journal. Because that way, you're indicating that you've done this work, you get credit for the work, that, hey, this is the person that did this work. So something out there, I feel, is better than nothing. You don't want it just sitting on your desk for months, and that's like the worst feeling. It gives me panic.
I would
And I
agree.
think one of the questions that really come to my mind, we speak a lot about research opportunities, but I want to hear briefly both of your opinions on non-research activities that make you a good fit for an oncology program. So what do you think about that? Dr. Warsame, you want to tell us?
Yes, I think I've seen some incredible volunteer work, nonprofit work, policy work. I'm I'm so impressed with medical students today. Like it's quite looking at their applications is so inspiring, because I think even dedicating yourself to, I had hospice work. There was many a patient who've been medical students who were LPNs or did hospice work and describe taking care of patients in such beautiful ways. I think that matters. I think medical education and curriculum showcasing, maybe you're going to be a teacher one day, maybe you will be a mentor and you're going to focus on how to teach adults medicine or different aspects of medicine. I think all of those, it really builds the idea is the application is going to build a good insight into the person and what they're hoping to do. And so I think there are lots of other non-research related things. Even if you just go to if you go to the NCI or NIH, there are shadowing programs, and that's impressive.
And do you want to add something, Dr. Chastri?
No, not really. I completely agree with everything Dr. Warsame just said. Just being able, even advocacy work, like I said, as a medical student, that's mainly what I did. I just did advocacy and policy work. And, I did very little to no research, medical research. And I think that was actually quite valued in my residency applications as well, that I showed leadership, in this particular role. And I think, just like she rightly said, I feel like volunteering or just directing your talents towards medical education and curriculum, if that's where your talents lie, I think is totally fine. And, will find a place on your application. Yeah.
Excellent points. And I think I would end up with this question. We have a few questions that we're not able to go through. I'm sorry for that. But there is a question I find interesting. Do you think that having a family history of depression is a contraindication to go for a career in oncology? And how can you handle those moments when you get depressed during your career path? And let me say a word about that because I'm finishing a training for now. And I think once you start oncology, it may be hard to deal with the emotions of patients if you get attached to it. But after all, I think it will get better. You will know how to deal with it, to help with it, and to get better every time you deal with it. What I can tell that you have people to help you through this, because you have mentors, you have attendings that did it before, probably were in having the same emotions that you may have, and just know how to deal with it. So I think this is one of the things that is tied to oncology, that it's a depressing subspecialty, but I don't see it this way. I see it that it is actually an opportunity to help patients that may be feeling depressed moments to get better. And I would love to hear briefly your opinion on that before we close. Dr. Chastri?
Yeah, no, this is a very good question, and I will say this, that, just working with patients that, have such a high risk of dying, I basically take care of patients with acute myeloid leukemia, which are, always many a times in a very critical state. And a lot of our patients, unfortunately, don't get cured even with the available therapies. It has actually helped me actually develop a better appreciation for life, and just being able to over time. And you're right, I've had those moments too through my training as a medical student or a resident fellow, where you get so attached to a particular patient. And even now as an attending, when they die, it's devastating. It does take a toll on you, but I think you're able to over time better reason with yourself, and you're able to just tie that into your life more seamlessly as time goes on, and try to understand what you learned from that and how you can go forward from here in a better way. So, and like Dr. Al Hadidi said, you have resources to help you. Like, so at my institution, we're lucky we actually have a clinical psychologist who does like rounds with us on the inpatient floor, and we just get to hang out with her, eat lunch, and talk to her about these difficult problems. Like, she comes once or twice a month. Yeah, so you have people that can help you get through it.
I would agree. I think no diagnosis would preclude you from doing a fantastic job as an oncologist. I think if depression was, we would lose many a physician. So I think we host every other month. We host events with all the attending staff and fellows and talk about it. There are people that we have death cafes. We talk about suffering. We talk about pain, things that you see that you can't necessarily discuss in regular conversation. But we often just talk about the joy of being present, because I think there's a quote in JAMA that always meant a lot to me, is that you cannot always treat, but you can always heal. And sometimes it's just holding somebody's hand and acknowledging and validating their experience. And that is just so moving. And like Dr. Shastri said, it has changed the way I live my life, because I know that absolutely nothing is guaranteed. And so it helps you appreciate the tiny moments. And so I hope that answers your question. I hope oncology doesn't always look so sad.
Thank you so much for the input. Those are great words. And at that time, I would like to remind everybody that this is the second webinar of a series of virtual sessions for medical students and residents. And all session recordings and details about past and future sessions will be posted on ASCO's social platforms and My Connection medical student resident community. Thank you for attending, and thank you, Dr. Chastri, Dr. Warsame, for this beautiful discussion, and good luck for everybody.
Thank you. Bye. Have a
Thank you
good
so
day.
much for having us. Take care.